Welcome to Cardio Radio, a podcast of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio. This is Dr. Michael Constant from the Case Western Reserve University School of Medicine, and I serve as the principal investigator for Cardio, a statewide network of Ohio's 7 medical schools. Cardio is funded by the Ohio Department of Medicaid and shares best practices to improve cardiovascular health, diabetes outcomes, and to eliminate health disparities in Ohio's Medicaid population. The opinions and recommendations in this podcast are those of the presenters and not those of Cardio and its sponsors, and are not intended to be a substitute for medical advice. I hope you enjoyed today's podcast.
Hello, I am Dr. Shanail Lampkin, a MedPeds physician and weight management specialist in the Metro Health System, assistant professor of medicine at Case Western Reserve University, and member of Cardio's team Best Practices. In this episode, I will be joined by pediatric cardiologist from University Hospital's Rainbow Babies and Children's Hospital, Dr. Sarah Tyler Plummer. Dr. Plummer is an associate professor of pediatrics at Case Western Reserve University School of Medicine with clinical interest in preventive cardiology. Dr. Plummer, thank you for taking time to talk with me today.
Thank you so much for having me, Dr. Berry. I'm looking forward to our discussion.
Let's jump right in. Dr. Plummer, it is well documented in the pediatric cardiovascular literature that childhood and adolescence are ideal windows to implement strategies for preventing atherosclerotic cardiovascular disease and cardiometabolic disease in adulthood. As a cardiologist, what do you see as the main problem that we are facing regarding prevention of cardiometabolic disease in our youth, and how has this evolved over time?
Without a doubt, the biggest threat is the childhood obesity epidemic. The most recent published data indicates that nearly 20% of U.S. children are overweight or obese, which is nearly 15 million kids. And this puts them at risk not only for becoming overweight adults, but also long-term for cardiometabolic syndromes, including diabetes and coronary artery disease. The childhood obesity epidemic is also intimately linked to the rising rates of hypertension in children. Hypertension is an increasingly common problem, and pediatricians should think about it daily in their practice. The true prevalence is not well known because this data is hard to gather, but it has been estimated that roughly 1 to 3% of children in the U.S. have hypertension. And even if it's as low as 1%, that's 740,000 children here in our country. That's higher than the prevalence of epilepsy and diabetes. Even more frightening, based on new diagnostic criteria and data, the estimated prevalence of hypertension is as high as 5.8%, because the previous estimates excluded children with overweight and obesity, which is now more than 1 out of 20 children who have hypertension. And I know what a general pediatrician's template looks like every day, and that's at least 1 kid with hypertension per day, more like 1.5 in a busy pediatric practice. Again, this is relevant because elevated blood pressure in children has been linked not just to intermediate outcomes of cardiovascular health, but also to cardiovascular disease-associated mortality.
So who then would you say is at highest risk?
The highest rates of obesity are in adolescents, so the risk does go up over time. When we look by race and ethnicity, the rates of obesity are highest in non-Hispanic Black girls and Hispanic boys at about 30% for both groups. There is likely a strong socioeconomic component to this, which contributes to long-term healthcare disparities in these populations.
Aside from these important factors, what familial or historical factors should we look for that may predispose young people to cardiometabolic disease?
Family history of early cardiovascular disease in a first-degree relative is a known independent risk factor for future cardiovascular disease. This includes heart attack, treated angina, coronary catheter interventional procedure, coronary artery bypass surgery, stroke or sudden cardiac death before 55 years of age in males and 65 years of age in females. So this is always part of my history. And I also focus strongly on grandparents as well in our pediatric patients, since the parents may be too young to have developed even early onset cardiovascular disease. Now, in terms of personal risk factors, a history of prematurity, congenital heart disease, both repaired and unrepaired, and or chronic kidney issues, including recurrent urinary tract infections, are known to add to the risk of cardiovascular issues later in life. Additionally, solid organ or bone marrow transplant status, any history of malignancy, or other systemic illnesses that can be associated with hypertension, such as sickle cell disease and tuberous sclerosis, are on the list.
So, how do maternal conditions like gestational diabetes and preeclampsia relate to screening recommendations for cardiometabolic disease in children?
There have been several studies following children born to mothers with gestational diabetes for up to 40 years that have shown that they do have an increased risk for hypertension. So this is a risk factor as well, although this one doesn't quite reach the threshold of increased screening, but it certainly needs to be on your radar.
That's good to know.
Children who are born to mothers with hypertension during pregnancy are also at increased risk, and the risk is even higher if the mother had chronic hypertension before and after pregnancy as well, with the incidence of hypertension being nearly 2.5 times that in the general population. Again, this doesn't meet criteria for increased screening, but it is a known risk factor and one that we should be looking for.
That is a great reminder for us to make sure we get a thorough birth history, even when seeing older children and adolescents with elevated blood pressures, overweight, and obesity. We'll come back to the discussion of hypertension in a few minutes. Let's pivot now to what we can control to help with obesity management. As our lives have become more sedentary, an unfortunate consequence for our children, as well as for adults, is that we consume more convenience foods and are, in general, less active, which has contributed to the rise in childhood overweight and obesity. Along with that trend are increases in chronic diseases like hypertension and hyperlipidemia. For those in primary care who may not have access to obesity management specialists, it can be daunting to initiate conversations about obesity, especially with younger patients, out of concern for stigmatizing them about their weight or body size. How do you initiate such conversations with the aim of harm reduction?
This is so hard, and it certainly hits close to home, even in clinician families like mine. It is such a balance between acknowledging it is an issue that demands attention and being cautious of not triggering body image issues and disordered eating. But it is typically true that if a child is overweight, they are not the only person in the family who would benefit from losing weight. And truly, for younger school-age children, they are not really fully responsible for their diet or activity level. Because of this, I try to engage in this discussion on a family level, largely because it's not fair or even possible in most cases to just change the diet of the child. These types of changes need to occur on the household level, and this is true to some extent with activity as well. While a child can be engaged in organized sports as an intervention to increase exercise, the family can also increase their activity level together. Honestly, it is rare to see a child truly have success without very active engagement from the parents and entire family. And thus, I encourage them all to work together on getting healthy. And this call to action can work.
This is good to know. Participation from the whole family is so important. What advice do you offer parents and caregivers to encourage children and adolescents to be more physically active?
I make 2 recommendations based on the 2018 Physical Activity Guidelines for Americans that recommend that all children get 60 minutes of activity per day, every single day. First, if able, sign your kid up for an organized sport. It's really hard to get an hour of activity per day without some impetus, something scheduled on the calendar. My second recommendation is to make physical activity a family affair. These lifestyle changes can be beneficial to the entire family unit and should be recommended as such. If it's in the family budget, suggest they consider joining a gym or recreation center and get everyone there 2 to 3 nights a week. Or the family can use a YouTube video on their smartphone or other device at home. There are lots of options these days. When the weather permits, they can walk outside as a family every weekend, get outdoors around home, or head to city or county parks. This can't be on the child to do alone. While the data is limited in my clinical experience, I've seen that interventions aimed at the entire family can be effective in improving blood pressure and lipids in pediatric patients.
Well, as anyone who has been involved in any aspect of child rearing can attest, it is often best to get some buy-in from the youth you are treating to encourage them to follow through on lifestyle changes, including diet and activity modifications to promote cardiometabolic disease risk reduction. Are there any strategies that you can share with us that have been successful for you in helping youth move toward these aims?
This is so hard because kids and teenagers, they feel invincible. So it can be difficult to get them to worry about the future health implications of how they live now, when they are for the most part decades away from serious problems. That being said, when there's a scary family history, a grandparent has died or even worse, mom or dad died, that can certainly get their attention. But even in the absence of that, I find that I can usually engage them. I tell them that their genes, their family history, they have no control over that. It's set. But they still have the ability to have a healthy heart and live a long, long time. So I tell my patients, while you cannot control the hand that you were dealt with your genes, you can control you, how you play your cards, and you can be healthy. And that is your job. Now that I'm your cardiologist, it's my job to help you do that. And it's your guardian's job too, to help you on that journey. And ultimately, it will help them too.
It's certainly a team effort to get children and teenagers to buy in. You mentioned that lifestyle changes are important in managing hyperlipidemia, but what about the effect of sleep on at-risk pediatric patients? We hear a lot about this in the fall and with the time change. Early school starts, late-night practices and activities, generally packed schedules for kids and teens. What can you tell us about circadian contributions and sleep deprivation in young people in terms of their cardiometabolic risks?
There is evidence that irregular sleep habits can cause circadian dysfunction, which can contribute to increased cardiometabolic risk. And this link between sleep and cardiometabolic disease has recently received more attention. It is hypothesized to be through several pathways, including increased inflammation, contributing to the development of atherosclerosis and abnormalities in cortisol levels. Irregular sleep has also been correlated with poor dietary habits, an increased total caloric intake, and gut microbial imbalance, all of which increase the risk of obesity. So in teenagers that we know have irregular sleep habits, improving sleep hygiene and practice can have numerous benefits when it comes to cardiovascular health, amongst other things.
Lifestyle and sleep are clearly important factors for obesity management in children and adults. Let's change gears a bit and focus on another cardiovascular risk factor, hyperlipidemia. In the care of adult patients, we sometimes use markers like apolipoprotein B and high-sensitivity CRP to provide more evidence of cardiovascular disease risk, in addition to the traditional markers like triglycerides, HDL, and LDL. Are these markers useful in the pediatric population, or are there other markers we should look at? And should we be collecting this information when assessing higher-risk pediatric patients?
Unfortunately, there is not good data on what these markers mean in children. Thus, the best place to start is with the risk assessment that we discussed earlier, including BMI, blood pressure, personal history, and family history, and then a standard lipid panel. I have had several children with concerning family histories come to me with these markers drawn, and it does not alter my practice in children. Either way, they would be followed closely with aggressive management of hypertension or hyperlipidemia if present.
That's really good to know. But one of the challenges faced by primary care providers seeing children and adolescents in the outpatient setting is that it is challenging to obtain a fasted blood cholesterol level. Is it okay to use a non-fasted cholesterol for risk assessment and stratification?
Non-fasting levels are appropriate for screening labs. However, as per the current guideline, it is my practice to counsel my patients that if the non-fasting level is abnormal, they will have to have them redrawn. So most of them do choose to draw them fasting. By the time they come to see me as a specialist, they are more concerned and more likely to have the lab drawn. A recent paper published in the Journal of the American Medical Association from July of this year documented that only 10% of pediatric patients have lipid screening at the recommended 9 to 11 year time point when all patients should be screened. So truly, if it's between not having it drawn at all and getting a non-fasting level, please get the lab drawn. Because of those who were screened, nearly 1/3 had abnormal lipid levels, which you could argue is because those who are at higher risk are more likely to have the lab ordered and actually drawn, but regardless, this is a staggering number, and we need to do better with screening, which is currently recommended to be performed once at 9 to 11 years of age in all patients, and if normal, again at 17 to 21 years of age.
What about therapy for high cholesterol in kids? Is this something that you commonly prescribe?
Lifestyle changes are the first-line therapy for hyperlipidemia in kids. Luckily, needing to treat hyperlipidemia in kids with medications is pretty rare, though we do use omega-3 fatty acids and statins in kids all the way down to 8 years of age if we have to. The American Academy of Pediatrics Guidelines for Lipid Management has very specific recommendations based on the fasting cholesterol levels, 2 labs drawn and averaged, plus personal risk factors. And there are very detailed algorithms for both high LDL and high triglycerides. But once you get to this point, you really should be consulting a specialist.
So, thus far, we've discussed assessing cardiovascular risk in children based on risk factors like obesity, prenatal history, and inadequate sleep, along with how to diagnose and manage children with hyperlipidemia. Let's circle back to hypertension. How is the diagnosis of pediatric hypertension made? I know this is a bit more complicated than the other cardiometabolic conditions discussed thus far.
The 2017 Clinical Practice Guideline for the Screening and Management of High Blood Pressure in Children tried to simplify the diagnosis of hypertension in kids. But it's still difficult because, as we know, kids are not just little adults. Even just getting an accurate blood pressure in a young child can be difficult. But normal blood pressures in kids are age, gender, and height dependent, and we have to use percentiles up to the age of 13 years. Thankfully, in this new guideline for children 13 and up, they did simplify things for us, and they used the same cutoff as adults, with less than 120/80 millimeters of mercury as normal, 120 to 129 as elevated blood pressure, 130 to 139 as stage 1 hypertension, and 140 millimeters of mercury and above as stage 2 hypertension. And this diagnosis is based on in-office blood pressures, because we do not have good normative data on home or school blood pressures in kids. So these modalities can be used to follow blood pressures over time, but should not be used to make the diagnosis of hypertension. The diagnosis should be based on 3 in-office measurements at separate appointments, with each being an average of 2 manual blood pressures.
Okay, so let's say I've made the diagnosis of stage 1 or stage 2 hypertension in my office setting. Should I be prepared to start an antihypertensive, or is it best to refer to a pediatric cardiologist or even nephrologist?
I would recommend referring at this point to either pediatric cardiology or nephrology to take over the diagnostic workup and subsequent management. Both pediatric cardiologists and nephrologists can and do manage pediatric hypertension, and it is somewhat region or center specific as to who is the primary subspecialty, so it's useful to know who to refer to in your community. It's most useful for patients to come to me with the 3 abnormal blood pressures documented and the diagnosis of hypertension made, and I can easily take it from there. Depending on the patient's age and risk factors, they may require a more significant diagnostic evaluation that is best guided by a specialist, and typically includes labs, and could include renal imaging and echocardiography. It would likely include an ambulatory blood pressure monitor, and while it would be reasonable for a provider to start therapy, I expect that most would feel that hypertension management is somewhat outside the scope of their usual practice in the care of children. So feel free to send them our way.
If I don't have one of these specialists in my area, how do I go about selecting the best antihypertensive for the patient?
Which agent to choose is largely based on provider preference, as the current guideline recommends ACE inhibitors, angiotensin receptor blockers, long-acting calcium channel blockers, and thiazide diuretics equally.
Great. You mentioned the use of ambulatory blood pressure monitoring. Can you tell us a little bit more about this test and how it helps with the diagnosis and management of pediatric hypertension?
Ambulatory blood pressure monitoring is a 24-hour monitor that we can use in kids aged 5 years and up to see what their blood pressure is outside of the office setting. They wear a blood pressure cuff for 24 hours that inflates every 20 to 30 minutes. Because blood pressures outside of the office are different than resting clinic blood pressures, there are different normal values. And ambulatory blood pressure monitoring has been shown to be more accurate for the diagnosis of hypertension than clinic-measured blood pressure, and more predictive of future blood pressure long-term. To understand the utility of ambulatory blood pressure monitoring, it's helpful to understand several hypertension concepts. Briefly, most people have heard of white coat hypertension, the phenomenon where an individual's blood pressure is high in the office but normal at home. Thus, it is recommended to perform a 24-hour ambulatory blood pressure monitor in children after elevated blood pressures in the office to confirm the diagnosis of hypertension, because it has been shown that about half of kids with high blood pressure in the doctor's office have white coat hypertension. So ambulatory blood pressure monitoring can make the diagnosis of white coat hypertension versus true hypertension. White coat hypertension, as you would expect, is more benign than true hypertension, but it's not risk-free, as these individuals are at increased risk for developing sustained hypertension, and thus require continued follow-up. Ambulatory blood pressure monitoring can also be useful to identify the presence of masked hypertension, which is when blood pressures in the office are normal, but they are elevated at home. Masked hypertension is more common in children with specific risk factors, including those with repaired coarctation of the aorta and obesity. And thus, routine surveillance with ambulatory blood pressure monitoring is recommended in these higher risk patients to screen for masked hypertension. Last but not least, ambulatory blood pressure monitoring can be useful after the diagnosis of hypertension has been made to monitor for adequate blood pressure control on therapy.
Thank you so much for explaining ambulatory blood pressure monitoring in such great detail. This will certainly help primary care providers feel more confident in making the diagnosis of hypertension in these patients. In thinking about the effect of our patients' lives outside of the office on their health and cardiovascular risk factors, it follows that we speak a lot about the social determinants of health in medicine these days. Some drivers for increasing risk of cardiovascular disease in our youth include neighborhood safety, socioeconomic status, sleep behaviors, as discussed earlier, and dietary habits, none of which are easily modifiable by a primary care provider. What are some of the ways you have seen these social determinants of health impact the cardiovascular health of our patients? And what are some ways that you recommend evaluating for and or managing these additional challenges to improve cardiometabolic risk in these patients?
Social determinants of health play such a significant role in ultimate health outcomes that it's hard to even know where to start. It spans all the way from access to care, to access to healthy food, to being able to participate safely in physical activity, to housing insecurity. It's hard to tell a family to avoid fast food and junk food when they don't have access to anything healthier. It's hard to tell a family to take more walks when they live in a dangerous neighborhood. And it's hard to refer someone to see a pediatric dietitian when they do not have transportation to access that care. And this is why when counseling, you have to try to ensure that what you tell a family resonates with them as possible and reasonable. Then, try and provide access to resources when you can. This is where resources including social workers and community health workers can be very useful if available.
Dr. Plummer, thank you for sharing your insights and expertise with our listeners. You've painted a compelling picture of the importance of screening and healthy lifestyle, and it will hopefully go a long way to keep lots of hearts very healthy in our youth and teens. Thank you for your time.
Thank you so much for having me.
And a special thank you to you, our listeners, for tuning in to Cardio Radio.
This concludes today's podcast. Be sure to visit cardio.org to learn more about the Ohio Cardiovascular and Diabetes Health Collaborative.